So hi everyone, I'm Dr. Deepthi and I would be discussing the Obs and Gynae CBT questions today for the FMGE exam. So let's start looking at the first question. So this question says that the patient has dysmenorrhea and menorrhagia. Okay, there is a tender and a diffusely enlarged uterus and there is no adnexal tenderness. The biopsy report is normal. What is the likely diagnosis, right? So the answer is going to be adenomyosis. So why is it not endometriosis? So please remember, in endometriosis, the uterus would not be enlarged. Okay, so here the uterus has to be normal size, right? Again, even in endometritis, which is infection or inflammation, the uterus would not be enlarged. Okay, then when we talk about uterine sarcoma, yes, the uterus can be enlarged, but since it's a malignancy, it's unlikely to be diffusely enlarged. Okay, and typically, instead of saying the woman will present with menorrhagia, the sarcomas will usually present as post-menopausal bleeding. Okay, now please remember, whenever we have these keywords, a tender uterus, a diffusely or a symmetrically enlarged uterus, then we should definitely think of what? Adenomyosis, right? So that is why we also use the term globular with it. Okay, so if we say it's a globular uterus, then again the answer is going to be adenomyosis. Remember, more common out of the two is menorrhagia. Dysmenorrhea is, yes, also common, but not the most common complaint. So this is, dysmenorrhea basically helps you differentiate it from fibroid uterus. So remember, Rakna, ki fibroid mein the uterus is going to be irregularly enlarged, not symmetrically enlarged. Okay? Right, let's look at the next question. Which of the following is absolute contraindication of copper T? Right, so the answer is going to be unexplained bleeding. Please remember, history of PID or history of ectopic, these as well as dysmenorrhea are only going to be relative contraindications. They are not absolute contraindications. So undiagnosed bleeding, or if my patient has a suspected pregnancy, or if the patient has a uterine abnormality where the cavity of the uterus is distorted, right? So if the cavity is distorted in shape, now the distortion in the shape of the cavity could be because of, Mullerian anomalies, it could be because of fibroid uterus, right? But if it is a distorted cavity, we would not put a copper T, or even a Mirena for that matter, right? Apart from this, it has to be a current pelvic infection, not the history of pelvic infection, but it has to be a current pelvic infection, and then yes, it is going to be a absolute contraindication. Also remember, when we talk about copper T, Wilson's disease will also be a absolute contraindication. Yes, so these are important things. And please remember, when we talk about copper T, their main mechanism of action of as a contraceptive is inhibition of fertilization. So when we ask about copper T, remember, they will not inhibit ovulation. Okay, so they do not inhibit ovulation, but yes, they will do what? They will inhibit fertilization, they will inhibit implantation, but they will not inhibit ovulation. Okay, so that is not their mechanism of action. That is again important thing that we tend to ask. Okay, so remember, absolute contraindications are important. Also, copper T is a emergency contraceptive. In fact, it is the most effective emergency contraceptive, and therefore if a lady comes to us, with on the 5th day of unprotected intercourse, the best answer should be copper T. Okay. Then let's look at the next one. So your patient is 39 weeks. She has had a myomectomy. Okay. Now, during the second stage, there is fetal bradycardia and there is bleeding. The fetal head, which was at +2, is now at -3. So a very, very characteristic clinical picture for rupture uterus, right? So please remember when they say कि station was +2 मतलब बहुत नीचे था and now it is at -3 ऊपर चला गया, this is what is called as loss of station. Okay, so this is what is called as loss of station, and this is actually characteristic to rupture uterus. So this is the most specific sign. If we ask you the most common sign, it is fetal distress. Okay, so then the answer will remain as fetal distress. Also, yes, it presents as bleeding, and that is why, you know, it is a DD for abruption. So abruption में भी क्या होता है? There is going to be bleeding and there is going to be fetal distress. So how do you decide whether it is abruption or rupture? So if it is a rupture uterus, you should know that loss of station is characteristic to it. It is not seen in abruption. Secondly, in rupture, the fetal parts will be superficially felt. Yes. And in abruption, what about fetal parts? Here in abruption, they're difficult to feel because it is a tense uterus, right? Also, as I said that it is a tense uterus in abruption, what about the contour? So in abruption, the contour is very well made out. It stands out. But if it is a case of rupture uterus, then please remember the contour of the uterus is lost. Uterine contractions will also stop. So contractions will stop, the contour is lost, right? Whereas in abruption, the woman will continue to be in labor. The contour is very well made out. The bleeding here is going to be altered in color in abruption. Whereas it is a dark colored bleeding in abruption. Whereas when you talk about rupture uterus, it is a bright red bleeding. Okay. All right. Now, your patient is a postmenopausal woman and she is coming with bleeding. Whenever we talk about postmenopausal bleeding and if we ask you what is the next step, then for postmenopausal bleeding, our next step is to be answered as transvaginal ultrasound, right? So that is done for her and we are looking for what? We are looking for endometrial thickness. So now the thickness is 6 mm. So you have to know if the thickness is more than 4 mm, then the patient may have high risk for cancer and therefore this patient needs to undergo a endometrial biopsy, which means we need a histopathological examination from the uterus. Now the histopathological examination from the uterus can be done through an endometrial biopsy. है ना, या तो हम endometrial biopsy कर सकते हैं, which is also considered as investigation of choice. Okay. But can we also do a curettage? Yes. So the difference is that biopsy is something which is done in the OPD itself. But when we talk about curettage, it is also a method of getting sample from the endometrium and it is the best method to take the sample. So it is the gold standard method. But farak kya hai ki curettage has to be done in the OT. So generally we consider it as gold standard but not IOC. So IOC is taken as an endometrial biopsy. But if biopsy is not in the options, like in this question, there is no option for endometrial biopsy, then we have to go for curettage. So this has to be done to rule out cancer. So you should be very sure on what to mark when it comes to PMB. Please remember when we talk about postmenopausal bleeding and we ask you the most common cause, right? You have to answer it as atrophy. Okay, so the most common cause is atrophy. Remember, only up to 10% patients of postmenopausal bleeding may have cancer. And also when we talk about cancer in postmenopausal women, your first suspicion should be endometrial cancer. See, if we have to talk about cervical cancer, then we will not talk about postmenopausal bleeding. We will usually talk about postcoital bleeding. Also remember, cervical cancer is more common in younger women. It is endometrial cancer which will be more common as the age increases. Okay. Okay, so all are true about the infection shown below except. So this is a very characteristic image of what? A clue cell. है ना? And do you all remember what is a clue cell? it is a epithelial cell, superficial cell. That is why it looks pink. So it is a superficial epithelial cell. And this boundary, do you see? It is all studded with bacteria, right? So it is a epithelial cell which is studded with bacteria. And which bacteria are they going to be? Yes, so it has to be mainly answered as what? Gardnerella vaginalis, right? So the main organism here is Gardnerella vaginalis. Okay, so we are talking about bacterial vaginosis. Now let's look at the options. Do they present with foul smelling discharge? Yes, this is the main presentation, and you should know that the discharge can be off-white or even gray in color, but yes, it has to be foul smelling. Okay, then the pH of vagina is more than 4.5. That's right. So for bacterial vaginosis as well as for Trichomonas vaginalis, again the pH will also be more than 4.5. सिर्फ कैंडिडा आपको याद रखना है as far as infections are concerned, where the pH will be less than 4.5, right? Whiff test is positive, yes. So when you add 10% KOH to the discharge, right? So when you add 10% KOH to the discharge, then this is where we will see what? Then we will see a positive whiff test, which is nothing but a amine odor. Okay, so it will be a amine odor. Please remember, whiff test is primarily done for bacterial vaginosis, but it may be positive in trichomonas as well. Okay, now the answer here is B. Why? Let's see. Because the ratio of epithelial cells to polymorphonuclear cells has to be more than 1. Okay, not less than 1. It is more than 1 in bacterial vaginosis, and this ratio will be less than 1 in Trichomonas vaginalis. Why? Because this bacterial vaginosis is vaginosis. It is not vaginitis. So inflammatory cells बहुत कम होते हैं, तो ज़्यादा क्या होंगे? Epithelial cells. So the ratio will be more than 1. Okay, in general, please remember the treatment of choice for this is metronidazole. But if they ask you with respect to syndromic management, then you have to answer as kit 2, which is going to be the green kit. Okay. Chalo. Let's look at the next question. So your patient is 38 weeks pregnant. Her cervix is 8 centimeters dilated. Vertex is at -1. Now, over next 2 hours, she is getting contractions every 2 minutes, so adequate contractions. But the cervix and the station remain unchanged. Another 2 hours, again there is no change, which means we now have a total of 4 hours of no cervical change, okay, in active phase with adequate contractions. What are you dealing with? So we should know that here we are dealing with arrest of active phase. This is the definition of arrest of active phase, right? And when we talk about arrest of active phase, you should know that the most common cause for this is going to be cephalopelvic disproportion. So that is going to be the answer here, right? Please remember, if it is arrest of active phase, right, what is the management? Then we have only one management, okay? The management is going to be cesarean. When we talk about arrest of second stage, and आपको याद होगा, second stage का मतलब है the cervix is fully dilated. Only then it is, arrest of second stage. So cervix has to be fully dilated. In primigravida, we can wait for up to 3 hours before we can call it as arrest, or we can call it as, in multigravidas, we have to wait for at least 2 hours before we call it as arrest. Now, farak kya hai? If it is arrest of second stage, then I can do a cesarean section or I can do instrumental delivery. How will we decide what is to be done? please remember, if there is any evidence of CPD or abnormal pelvis, then we will do a cesarean. But if there is no CPD and criteria for instrumental delivery are met, then we will do a instrumental delivery, right? Can you do instrumental delivery in second stage even with fetal distress? Yes. सेकेंड स्टेज में फीटल डिस्ट्रेस के साथ भी इंस्ट्रूमेंटल डिलीवरी की जा सकती है प्रोवाइडेड द क्राइटेरिया आर मेट. ठीक है. ओके. So a woman is undergoing infertility treatment and she has the following image in ultrasound. So this is what you see as big and multiple follicles in the ovary. Right? So which means it is a overstimulated or a hyperstimulated ovary. So which drugs are going to cause a hyperstimulated ovary? Yes, it has to be gonadotropins, which means injection HMG, human menopausal gonadotropin, right? So this is which has the highest risk of hyperstimulation, right? And now please remember, this woman can also land up with hyperstimulation syndrome, right? So if she develops syndrome, the symptoms, it will become OHSS. So sometimes they'll show you the same image and they will give you some symptoms. Like they will say the patient has abdominal pain, then they will say she has nausea, she has abdominal distension, right? So if we give you this image and these symptoms, then the answer has to be OHSS. Please remember, this is not PCOS. Why? Because in PCOS, it has to be small follicles. They have to be less than 1 centimeter in size. So they're not these big follicles. Okay. Acha, don't confuse with injection HCG. Injection HCG doesn't stimulate the ovary. It will cause, it is used as a trigger for ovulation. So क्या होता है? Once you hyperstimulate the ovary, if you give the trigger, then she will develop the syndrome. So it is not the one which is stimulating the ovary, but it is the one which is going to cause the symptoms. ठीक है? So yes, अगर मैंने इस patient को अब trigger दे दिया, then yes, she will develop the syndrome as well. Okay? Okay, so all the following are correct lab associations with this except, so this is yes, an ovary with PCOS. Why? Because you see multiple small follicles, they're also arranged in the periphery, which is what is called as necklace pattern, also called as what? String of pearls, right? Now please remember, there is no doubt that necklace pattern or string of pearls is characteristic to PCOS, but it is not a diagnostic criteria. Okay. Now, do we see raised LH? Yes. So we will see persistently raised LH levels. Matlab throughout the cycle, the LH levels will be raised. Do we see normal FSH? Yes, this is also true. The FSH will be in the normal range. It may be a little less, but it's not suppressed. It will always be in the normal range, which is around 4 to 10 international units. Absolutely, there is amenorrhea or oligomenorrhea, but the prolactin levels will be normal. So the answer is raised SHBG. SHBG levels have to be low. Why? Because there is suppression of HBG by androgens and by insulin. Right? So please remember, these two things, androgen and insulin levels, they are raised in PCOS. So they cause a negative feedback. Also, please remember, in PCOS, usually the E2 levels are going to be normal, but it is E1 which is going to be raised. E1 का क्या नाम होता है? Estrone. Where is it formed? It is formed in the adipose tissue, not in the ovary. Right? So it is formed in the adipose tissue from androgens. Okay. Which is not correctly paired. Right? So the answer is going to be C. When you say gonadotropin levels, what do we mean? We mean serum FSH, and it has to be done on day 3 of the cycle, not day 21. What do you do on day 21? You do serum progesterone levels, right? What is the use? Serum FSH is the most commonly used test of ovarian reserve, while serum progesterone is most commonly used test of ovulation. Okay, so we say if progesterone levels are more than 3 nanograms, then the cycle is ovulatory. Very, very important. Please remember, yes, endometrial biopsy is done on day 26, which is called as the premenstrual phase. Don't confuse with this HSG, which is done in the post-menstrual phase, right? So it is usually done from day 6 to day 11 of the cycle, right? Post-coital test, yes, can be done from day 12 to day 14. It is a test to look for what? Anti-sperm antibodies. Endometrial biopsy क्यों करते हैं? So endometrial biopsy is basically also one of the tests of ovulation. और HSG क्यों करते हैं? HSG is the investigation of choice for tubal patency. So it's a very important question that gives you a lot of important probable MCQs as well. Chalo. Which of the following is an indication for surgical management of ectopic pregnancy? So ectopic sac with cardiac activity is the answer here, right? So please remember the upper limit to do medical management for HCG is 5,000. So here it is less than 2,000, so we can definitely do medical management. Patient desires future pregnancy, we can still do medical management provided requirements are met. And yes, very importantly, if it is an unruptured ectopic, then our preferred treatment is medical. Okay, मगर अगर यहीं पे हम लिख देते ruptured ectopic, then you have to know that for ruptured ectopic, our preferred treatment is surgical. Again, ectopic with cardiac activity, our preferred treatment is surgical. If the patient is hemodynamically unstable, or if she has a sac size which is bigger than 4 centimeters, if she has HCG which is more than 5,000, or if the family is complete, in all these conditions, we will also do surgical management. Also, something which is very obvious, if medical management fails, then also we have to do surgical management. Okay. Right. So your patient is 41 weeks pregnant and she has to be induced. Okay. What is not to be used in her? So the answer is going to be PGF2 alpha. Remember, PGF2 alpha is the other name for carboprost, also called as hemabate, right? So it is used where? It is used for treatment of postpartum hemorrhage. It is never used for induction of labor. PGE1 क्या होता है? Misoprostol. Right, so misoprostol is available as a tablet. It can be used for induction of labor. PGE2 is Cervi-Prime gel. It can also be used for induction, and membrane stripping or rupture of membranes can also be used for induction. Right, so PGF2 nahi use karte. PGF2 alpha is used for treatment of PPH. Please also remember, carboprost or PGF2 alpha is not to be used also for what? It is not to be used for AMTSL. We don't use it for prophylaxis. We use it for treatment of PPH. Okay? Please remember that misoprostol, although we are saying it can be used for induction, but you should not use it if the patient is a case of previous LSCS, because misoprostol is more likely to cause rupture. Okay, your patient has normal blood pressure, but her liver enzymes are raised and platelet count is less. Can it be still HELLP syndrome? Yes. Please remember, to say it is acute fatty liver, you should have signs of liver failure, because acute fatty liver is the closest DD of HELLP syndrome. So you have to know that no doubt it can present with deranged liver enzymes, but the most important thing is signs of liver failure, जैसे कि altered sensorium. Okay, then what else? Maybe she has hypoglycemia, okay, or maybe she has raised ammonia levels, okay, maybe she has rising serum creatinine levels, maybe she has DIC or a coagulopathy, right? So then yes, we will label it more like AFLP, but in this case ऐसा कुछ भी नहीं है, so we are going to go with HELLP syndrome. Okay, please remember इसके अलावा hemolysis भी होना चाहिए, and to look for hemolysis you are going to look for peripheral smear or you're going to look for serum bilirubin. Bilirubin levels will be raised and smear will show schistocytes. Now a doubt could be, ma'am, normal blood pressure हो सकता है HELLP में? Yes. So in up to 20% patients, okay, of HELLP syndrome, the blood pressure may be normal. 80% में तो हाई ही होगा, but 20% में normal हो सकता है. What about AFLP? AFLP में 50% of patients can have high blood pressure, 50% can have normal blood pressure. Okay. Okay, so your patient has undergone a vaginal delivery, मगर अभी क्या हो गया, जब हम placenta निकाल रहे थे, uterine inversion has happened, right? Which of the following should not be done? So please remember, we should not deliver the placenta right now. अभी और separate नहीं करना. This will cause a massive hemorrhage and the patient will die. So yes, you will call for immediate help. You will begin resuscitation and you will push the fundus back. So this is the most important step. You have to put the fundus back. This is what is called as manual repositioning. Okay, and manual repositioning is to be done in the labor room itself. We don't need to take the patient to OT. This is an obstetric emergency. Okay, and manual removal के method का नाम क्या है? It is called as the Johnson's method. Please remember, when you are pushing the uterus back, इस time पे I am not even going to give oxytocin, because to put the uterus back, we want the uterus to be relaxed. So if it is contracting, you will not be able to push it back. So abhi we don't need oxytocin. We will start oxytocin after we have pushed back the uterus. Okay. Also remember, the woman, if she develops inversion, then she will develop shock immediately after delivery. So whenever you see shock immediately after delivery, then this is what is inversion. And when we talk about shock after delivery, if it is immediate, remember this shock is usually neurogenic. Eventually the patient can die due to hemorrhage as well. So it can convert into a hemorrhagic shock, but the initial shock is going to be neurogenic. Okay, so all the following are seen with the following Mullerian anomaly except. So what Mullerian anomaly is this? This is a unicornuate uterus, right? So unicornuate uterus में transverse lie is not possible. All these other things are possible. See, abortions, because the cavity is small, and that is exactly why transverse lie is not possible. Endometriosis, because a lot of times in unicornuate uterus there is a other rudimentary horn, and in that horn there may be obstruction to the outflow of blood. So if there is obstruction to outflow, retrograde flow increase हो जाएगा और endometriosis हो सकता है. Similarly, they can have cyclical abdominal pain, which is again because of obstruction from that rudimentary horn. Right? Not only this, remember, unicornuate uterus is also associated with ectopic ovary. It is also associated with ectopic pregnancy. And please remember, this can cause unilateral dysmenorrhea. Also, unicornuate uterus has highest association with What? Yes, with urinary tract anomalies. Okay, so it will have highest association with urinary tract anomalies. Remember, whenever we talk about Mullerian anomalies, investigation of choice is a 3D ultrasound. Okay, and when we talk about gold standard, it is going to be MRI. And when we talk about best procedure, it is going to be a combination of laparoscopy and hysteroscopy, right? So, which is rarely needed to make a diagnosis. But yes, when you are in doubt and none of the radiological investigations help, then I will have to do a laparo plus hystero. Okay. The most important indication for surgical repair of this uterus. So if you look at this uterus, there is a narrow angle between the two horns. So what did I teach you? When there is a narrow angle, you will consider this as septate uterus. And what is the problem? Septate uterus will cause recurrent pregnancy loss, which is also called as recurrent abortions or habitual abortions. This is why we say septate uterus has worst reproductive outcome. And this is why we want to operate on her. So what is the procedure? We will do a hysteroscopic resection of the septum. Please remember, hysteroscopy is a transcervical procedure. So sometimes they will use this word to confuse you. So it is transcervical. Okay. What condition in the mother is associated with the following fetal abnormality? So this is a typical image of caudal regression syndrome, also called as what? Sacral agenesis, right? So ये किसमें मिलता है? You will see this in overt, or we say pre-gestational diabetes. Please remember, gestational diabetes में anomalies नहीं होती. So gestational diabetes में ये नहीं मिलेगा. Also remember, this is the most specific anomaly in the baby of a diabetic mother. But if we ask you most common anomaly, then what is it going to be? Then it is going to be VSD. ठीक है? Okay, quadruple test is done between, it is done between 15 to 22 weeks. It is a test of second trimester and we use it for screening of Down syndrome. इसमें क्या क्या होता है? The 4 parameters are HCG, alpha fetoprotein, UE3, and it has to be inhibin A, not B. HCG or inhibin A raised होते हैं and alpha fetoprotein and UE3 will be less. Now, what you also need to remember is alpha fetoprotein Down syndrome में या trisomy में less होता है. मगर if the baby has, let's say, neural tube defects, not Down syndrome, तो AFP को क्या होगा? तो AFP levels high होंगे. Right? So then the AFP levels are high. So whenever AFP levels are high, you should suspect neural tube defects, even abdominal wall defects, right? और इन defects को देखने के लिए आपको क्या करना चाहिए? You should do a level 2 ultrasound. That will tell you whether the baby has anomalies or not. ठीक है, ये मैं तब बात कर रही हूँ when AFP levels are high. Low में जैसे कि हमने बोला is what is suggestive of Downs या trisomies. Okay. Your patient has come with recurrent pregnancy losses. She is 12 weeks pregnant. She's again had a missed abortion. Which investigation is not to be done? So the answer is VDRL. Please remember, infections do not cause recurrent pregnancy loss. Remember, when we say recurrent pregnancy loss in the first trimester, the most common cause will be chromosomal. When we talk about recurrent pregnancy loss in the second trimester, you will go with uterine abnormalities. Okay. APLA, yes, definitely can cause recurrent pregnancy loss. It can cause in both trimesters, but second is more common than first trimester. The typical antibody is lupus anticoagulant. But another one that you should remember is ACA, anti-cardiolipin antibodies. Okay, so please remember, infections don't cause RPL. ठीक है, एप्ला में प्लीज याद रखना, एप्ला एक तो अबॉर्शंस करता है और साथ में एप्ला और क्या कर सकता है, अगर अबॉर्शन नहीं भी हुआ तो आगे जाके प्रेगनेंसी में प्री एक्लैम्पसिया हो सकता है. सो इवन दैट हिस्ट्री वुड टेल यू दैट इट इज लाइकली टू बी एप्ला. ओके, estrogen levels are normal in all the following conditions except the answer will be Sheehan's. Sheehan's में क्या है, pituitary का infarction. Yes, so there is a pituitary infarction, and if there is an infarction, all the hormones that are coming from anterior pituitary will be reduced. So there will be reduced FSH, reduced LH, reduced prolactin levels, right? Even thyroid levels will be less. Now what you have to know is, because LH and FSH are less, there will be no stimulus to the ovary. And if there is no stimulus to the ovary, will it produce estrogens? No. Though, so estrogen levels will be low. PCOS में अभी मैंने बताया estrogen levels are normal. खाली अगर वो obese patient होगी, only in that case it may be raised. ठीक है? Asherman's is a problem not with the ovary. It is a problem with the uterus. There are intrauterine adhesions, also called as synechia. So, उसमें क्योंकि ovary is functioning normally, that is why the estrogen levels will be normal. Similarly, imperforate hymen. The ovaries are normal. So, in all these three conditions, the ovaries are normal. They also have a normal stimulus, and that is why the estrogen levels will be normal. ठीक है? What about Turner syndrome? भाई Turner syndrome में ovary नहीं है, तो इसीलिए what will happen to estradiol levels? They will definitely be low levels. ठीक है? Okay. What is the correct obstetric formula? Right? So एक lady है who is pregnant for the 5th time. So now, which means obviously the answer can be either A or it can be C. It cannot be B and D, because gravida is the number of times the woman has been pregnant. So ये G5 हो गया. Now let's look at this. So now we have to see TPAL. This is number of term pregnancies, matlab beyond 37 weeks, and we have to talk about completed pregnancies. We don't look for current pregnancy. P means preterm. So pregnancies that were completed between 20 to 36 weeks. Again, it is a completed pregnancy, so current is not included. Abortions, you know, pregnancies that were ended before 20 weeks. L, please याद रखो, number of currently living children होता है. हम ये नहीं पूछ रहे बच्चा मरा हुआ पैदा हुआ या नहीं. We are concerned about कि currently living है कि नहीं. अगर वो लाइव बॉर्न था बट इट डाइज लेटर, इट विल नॉट बी काउंटेड इन लिविंग. ठीक है? सो नाउ शी हैज हैड 1 ट्विन डिलीवरी एट 34 वीक्स, मतलब एक प्री टर्म डिलीवरी हो गई उसकी. बोथ बेबीज आर अलाइव, तो 2 बच्चे तो ऑलरेडी हमें पता लग गए अलाइव हैं. देन शी हैज हैड 2 अर्ली अबॉर्शंस, तो ए हमें पता लग गया 2 है. And 1 delivery of a IUD baby at 37, मतलब टर्म पे है, मगर वो बच्चा is not alive right now because it is stillborn. So आंसर क्या होगा? 1122, which means we have to go with option A. ठीक है? अच्छा, प्लीज याद रखेंगे, ट्विन प्रेगनेंसी को आप प्रेगनेंसी एक ही मानेंगे. इट इज नॉट 2 प्रेगनेंसीज, राइट? सो इसीलिए हमने प्री टर्म को 1 रखा है, 2 नहीं रखा. ओके, ऑल राइट. नाउ योर पेशेंट हैज हैड अ टर्म डिलीवरी, लेकिन अभी क्या हुआ, उसको हाइपोटेंशन हो गया, शॉक हो गया और DIC हो गया. शी डज नॉट हैव एनी प्रीवियस कार्डियक कंडीशन. So please remember, whenever we talk about a sudden cardiorespiratory failure, you have to think of amniotic fluid embolism. Especially अगर वो DIC के साथ हो गया तो पक्का AFE है. पेरीपार्टम कार्डियोमायोपैथी, पहली बात तो सडन नहीं होती, और उसमें DIC भी नहीं होता, राइट. और पेरीपार्टम कार्डियोमायोपैथी इज नॉट अ रेस्पिरेटरी फेलियर, इट इज ओनली अ कार्डियक फेलियर, राइट. ओके, उसमें पेशेंट हार्ट फेलियर में जाती है. It is not inversion because again inversion will not present as sudden onset of breathlessness or cardiorespiratory failure. It presents as shock. यहाँ पे उल्टा क्या होता है, sudden onset of breathlessness और फिर shock, which is cardiac shock, not neurogenic. Inversion में neurogenic होता है. ठीक है. All right. Which of the following hormones is represented by green line? So अगर हम देखें, green line has high levels in the middle of the cycle. So now we have to know whether it is LH, FSH or estrogen. So LH का ना सबसे बड़ा पीक होता है at ovulation. So hormone C is LH. Estrogen का उससे थोड़ा छोटा पीक होता है और थोड़ा पहले होता है ओव्यूलेशन से. सो इसीलिए B इज एक्चुअली ईस्ट्रोजन. ब्लू कलर का जो यहाँ हार्मोन है, राइट, विच इज लेबल्ड एज D, वो है FSH. उसका मिडल में सबसे छोटा पीक आता है, राइट. एंड A क्या रह गया, प्रोजेस्टेरॉन. प्रोजेस्टेरॉन एक हार्मोन है जिसका सबसे बड़ा पीक आता है एंड आफ्टर ओव्यूलेशन आता है. ठीक है. So it is estrogen. Please remember the time gap between LH surge and ovulation is 36 hours. It is the single most important hormone for ovulation. अगर एक हार्मोन मार्क करना होगा तो हम LH मार्क करेंगे, ठीक है. बट बिफोर ओव्यूलेशन ये दोनों हार्मोन बढ़ते हैं, LH भी बढ़ता है और FSH भी बढ़ता है. So there is an increase in LH and there is an increase in FSH. But the increase in LH is more as compared to that of FSH. So it is the single most important hormone. Estrogen is a hormone which is higher in the first half of the cycle and progesterone is higher in the second half of the cycle. Okay. So now this is a patient whose LH and FSH are normal. Her breast development is also normal. Pubic hair is also normal, right? But there is a blind vagina and absent uterus. The karyotype is XX. So it cannot be Turner's. Turner's का karyotype is XO. And in fact, Turner's have uterus and absent breast. So ये Turner's नहीं है. Swire's is 46XY. उसमें भी uterus is present और breast development is absent. तो ये Swire's भी नहीं है. Then this is not even AIS because they have a karyotype of XY. And AIS में pubic hair बिल्कुल नहीं होने चाहिए. Pubic and axillary hair have to be absent. Whereas Mullerian agenesis are the ones which have XX. They will have absolutely normal pubic and axillary hair. They will have breast development. Also, the uterus will be absent. AIS may be the uterus is absent and the breast development is present, but they should not have normal pubic and axillary hair. Blind ending vagina से confuse नहीं होना है. I know we talk about blind ending vagina with AIS, but it can also be seen with Mullerian agenesis. So खाली vagina पे base करके answer mark नहीं करना है. Meigs syndrome. So Meigs syndrome is a triad of a benign fibroma, ascites and hydrothorax या pleural effusion. Fibroma is a sex cord stromal tumor. It is actually a common category, इसलिए इसको इस कैटेगरी में डालते हैं, नहीं तो ये एक्चुअली एक स्ट्रोमल ट्यूमर है. ठीक है. सो दिस इज व्हाट इज मीग्स. प्लीज रिमेंबर स्यूडोमीग्स में it can be any other tumor apart from these four. So Meigs में आता है fibroma, granulosa cell, thecoma और Brenner's. Apart from these four, if it is other tumor and with the same things, मतलब ascites and pleural effusion, तब हम उसको क्या कह देते हैं? Then we will call it as pseudomeigs. So मीग्स कैन बी सीन विद दीज 4, बट कभी भी अगर पूछें एक आंसर बताओ मीग्स किसके साथ होता है, देन इट हैज टू बी आंसर्ड एज फाइब्रोमा. An interesting thing is, if you remove the fibroma, the the ascites and pleural effusion will spontaneously improve. ये अपने आप improve कर जाते हैं. You don't have to do any treatment for it. Okay. So that brings us to the last question. Your patient has heavy bleeding and for 3 months, she has also done some DNC at a hospital, but still she continues to bleed. What could be the reason? So लोकिया 3 months के लिए नहीं होता. लोकिया average duration is 1 month or 4 weeks, but it can sometimes go up to 6 weeks also, but not 3 months. DIC will not present as spotting. DIC will present as massive bleeding, right? And DIC में there would be some other risk factors given to you. Okay. Retained placenta. Again, retained placenta अगर हो गया, it will rather present as primary hemorrhage. मतलब within 24 hours. It will not present after 3 months. So most likely your patient has developed a choriocarcinoma. Why? There is history of DNCs also, right? So maybe there was some tissue which has been removed and it was a choriocarcinoma. So anytime you have bleeding which is going to be present after such a long time of pregnancy, think of a possibility of choriocarcinoma. Also please remember, जैसे कि मैंने कहा, प्राइमरी PPH इज यूजली व्हेन इट हैपेंस विद इन 24 आवर्स और उसका मोस्ट कॉमन कॉज है यूटेराइन एटोनी. सेकेंडरी PPH होता है विच हैपेंस बियॉन्ड 24 आवर्स अप टू 12 वीक्स. नाउ इसका रीजन होता है रिटेन्ड प्लेसेंटल टिश्यू. ना जब हम यहाँ बोलते हैं, इट डज नॉट मीन दैट एंटायर प्लेसेंटा हैज बीन लेफ्ट इनसाइड. इट जस्ट मीन्स maybe some bits and pieces, membranes, this has been left, and then it can present as secondary hemorrhage. Agar pura placenta ya a lobe of placenta has been left behind, then it will actually present as primary hemorrhage. Okay, so I hope you've done well and I hope you learn from your mistakes. Be ready for the next CBT. These are very important topics for your exam, so you must revise these topics. Also use DFX for your revisions, okay? So God bless you all and all the best. Okay, so I forgot that there are 4 more questions, so apologies. Let's look at this. So when does implantation begin? So implantation will begin on day 6 post-fertilization, okay? And it is completed by day 10. Also remember, implantation जब आप बोलते हो, this is going to happen in the blastocyst stage, and at this time some women may have bleeding और उसको हम कहते हैं Hartmann sign. And remember कि implantation is always eccentric, मतलब never in the middle of the cavity, it is towards one side. और इस sign को क्या कहते हैं? Pisca-sex sign. Pisca-sex is an early sign which you can see around 8 weeks, where you see a asymmetrical enlargement of the uterus. और उसका कारण क्या होता है? The reason for asymmetrical enlargement of uterus is that there is an implantation on one side, so that side grows first. Okay. If we ask you how does conceptus enter the uterine cavity, then please remember it will enter the uterine cavity as a morula, okay, on day 4 in the 16 cell stage. Okay, so a basic but an important question. Placenta is formed from frondosum and decidua basalis, right? So chorion frondosum forms the placental tissue, whereas decidua basalis will form the bed, okay? Eventually, please remember, decidua parietalis and capsularis are going to fuse, right? So this happens around 16 weeks. So eventually they are going to fuse. ठीक है? Now please remember कुछ basic चीजें placenta की आनी चाहिए, जैसे the weight at term is 500 grams, the blood is 500 ml, ratio of प्लासेंटा टू फीटल वेट एट टर्म इज 1:6 है ना. इसका डायामीटर कितना होता है 20 सेंटीमीटर्स और थिकनेस कितनी होती है. द एवरेज थिकनेस इज 2.5 but up to 4 is considered as normal. Okay, and always remember the cord will be attached to the center of which side, placental, maternal side or fetal side, fetal side, and the cord should have 3 vessels, है ना, 2 umbilical artery and 1 umbilical vein. So you must know these basic things, they are being asked in the exam. Okay, which statement about HCG are true except? So what is true? Not true is cytotrophoblast, because we know that it has to come from syncytiotrophoblast. And how early? It comes as early as day 8 post fertilization. Peak levels will reach at 10 weeks. है ना. Now इसके 2 सब यूनिट होते हैं. बीटा सब यूनिट इज स्पेसिफिक. दिस इज द ट्रू स्टेटमेंट. इसीलिए your urine pregnancy test या blood pregnancy test, they will all be based on the beta subunit. Doubling time is 48 hours. Yes, and if it is 48 hours, it will tell us that it is a live and a intrauterine pregnancy. So these are very important things about HCG. Please remember, HCG maintains corpus luteum of pregnancy, and it will protect it from undergoing luteolysis. Also remember, HCG is the first stimulus for what? For testosterone release from fetal testes. And remember, like progesterone, HCG will also reduce myometrial contractions. ठीक है, चलो. Which statement is not true about human placenta? अरे ये तो अभी हमने किया. The weight is 500 grams. ये तो सही है. But answer क्या है? Answer है B. It does not have 2 vessels. It will have only 3 vessels. है ना, 2 arteries and 1 vein. Remember बच्चा कि umbilical vein में oxygenated blood होता है. Okay? और artery में deoxygenated. Yes, it is important. It takes over the function of corpus luteum after 8 weeks. मतलब in the first 8 weeks, estrogen and progesterone will come from corpus luteum. ठीक है? But after 8 weeks, the estrogen and the progesterone are going to come from the placenta. ठीक है? चलो. Which statement about iron folic acid tablet of Government of India is not correct? So does it have 60 milligram of iron? Yes, ये तो सही है. 0.5 milligrams of folic acid, ये भी सही है. It is given as 1 tab per day, ये भी सही है. And we start at 12 weeks. Okay. Is it given for 100 days? No, no, no. It is given for 180 days. During pregnancy, मतलब 6 months during pregnancy, and 180 days मतलब 6 months after delivery. So answer 100 days नहीं है. Can you give it in the first trimester for treatment of anemia? Yes. अगर treatment के लिए देना पड़े, then we can give it in the first trimester as well. साथ में please याद रखो, as per the anemia मुक्त भारत अभियान, we will also do deworming. जिसके लिए we give tab albendazole how much? 400 milligrams. It has to be given in the second trimester and it's a single dose. First trimester में हम सिर्फ patient को folic acid देते हैं and we will give 0.4 milligrams. ठीक है? So this is what you usually do for all pregnant women, not the women at high risk. This is done for everyone. Also remember, hemoglobin estimation has to be done at all antenatal visits. So जितनी बार वो antenatal checkup के लिए आएगी, hemoglobin estimation has to be done. ठीक है? So चलो, all the best. Please revise these topics. They are very important for exams. CBT 2 भी जरूर देना है and DFX revise करते रहना है. These 2-3 things will give you the edge that you need. Okay, so all the very best to all my dear FMG bachas. Thank you so much, bachas.